Hello everyone, myself Dr. Atiya Kausar, Professor from Department of Microbiology, Sri Siddhartha Medical College, Tumkuru, would like to talk about hypersensitivity. We'll just have a talk with the small case scenario. A 8-year-old presents with cellulitis. She has never taken penicillin injection in the past. Now after she is given second dose, she collapses all of a sudden. What is the reason for this? Introduction. An immune response is a protective phenomenon. However, the reaction may be excessive and it may lead to gross tissue damage. This is called hypersensitivity. Sensitizing dose or primary dose is the contact with allergen which sensitizes the immune system. Shocking dose is the subsequent contact with the same allergen that causes manifestations of hypersensitivity. The term hypersensitivity refers to undesirable injurious consequences in the sensitized host following contact with specific antigens. There are two types of classification: traditional classification, immediate and delayed type; Coombs and Gell classification, where it is classified into four types: type 1, type 2, type 3 and type 4. Traditional classification, immediate and delayed, all three types are grouped in type 1 and delayed is grouped in type 4. This immediate type is basically through B cell mediated. It appears and recedes rapidly. Passive transfer with serum is possible. Desensitization is easy, but it is short-lived. Examples for this are anaphylaxis, atopy, Arthur's phenomenon, serum sickness. Delayed type, type 4 hypersensitivity is placed here. It is T cell mediated. It appears slowly. It lasts for a longer duration. Transfer is possible with sensitized T cells. Here, desensitization is a little difficult, but if achieved, it is long lasting. Examples are contact dermatitis and tuberculin type. Coombs and Gell's classification. Coombs and Gell classification, it is based on different mechanism of pathogenesis. So, the pathology and clinical features are contributed by humoral amplification system. So, it is classified as four types based on the pathogenic mechanism, whether it is IgE mediated, antibody dependent cytotoxic, immune complex mediated or cell mediated or delayed type. So, just a small mnemonic to remember in the long run: acid is for type 1 anaphylactic IgE mediated, type 2 cytotoxic, type 3 immune complex mediated, type 4 is cell mediated. So, antibody mediated reaction, here it is homocytotrophic antibody, it is because of mast cell binding; humoral antibody, complement fixation a little bit, humoral antibody, complement fixation, then receptor on T lymphocytes. Here antigen, antibody, this reaction where whatever it is happening, it is usually due to exogenous antigen in type 1 because of gross pollen structures. Here it occurs on the cell surface. Complex mediated is also extracellular. Cell mediated type, it is associated with major histocompatibility complex that is present on macrophage of the target cell. Response to intradermal antigen, maximum reaction is within 30 minutes, virulent flare appears. Basic pathogenesis, histological level, we see degranulated mast cells, edema as a late reaction, where cellular infiltration is predominantly because of eosinophils. In immune complex mediated, it takes about 3 to 8 hours to appear. We observe erythema and edema, acute inflammatory reaction. Predominant here we have polymorphs. Cell mediated or delayed type is 24 to 48 hours, where we see erythema and induration. Perivascular inflammation because of migrating polymorphs which are leaving the mononuclear cells are predominant here. Transfer sensitivity to normal subjects is possible here by using serum antibody. Here lymphoid cells transfer the factor. Examples here for anaphylactic, atopic, allergy, hay fever reactions. Here it is hemolytic disease of the newborn due to Rh incompatibility. Here we have complex glomerulonephritis. One more example is farmer's lung. And in type 4, we have Mantoux reaction to tuberculosis. Type 1 hypersensitivity. Antigen combines with cell-fixed antibody, leading to release of pharmacologically active substances which produce the reaction. There is a strong genetic predisposition in these cases, means that when we extract history from any case presentation, we can excite that there is any family history present in the family. There is a strong genetic predisposition for the development of immediate hypersensitivity. Type 1 reactions are brought about by allergens. So what exactly are these allergens? Allergens are small proteins or protein bound substances. It appears that allergen effects is a consequence of a complex series of interactions involving what all present in the allergen that matters and how it excites reaction, what are the contributing factors. It all depends on nature of the allergen, then the dose, about what amount is induced, the sensitizing route, whether it was oral or intravenous, and any adjuvant is present along with it. The genetic constitution of the recipient also matters here. Some of the examples of the common allergens, this I think in day-to-day life we might have elicited and we have faced in children, like some have allergy to peanuts, some are allergic to pollen substances, some have dust allergy, some are asthmatic. So just list of allergens in detail. Proteins, foreign serum or vaccines, plant pollens like ryegrass, ragweed, timothy grass, birch trees. Some of the drugs which can induce this anaphylactic type 1 hypersensitivity reaction like penicillin, sulfonamides, local anesthetics and salicylates. Foods such as nuts, seafood, eggs, peas, beans and milk. Some insect products like bee venom, wasp venom, ant venom, cockroach calyx, dust mites and mold spores, animal hair and dander. So we have to understand two concepts basically before we go in detail to understand the mechanism of hypersensitivity. One was allergens. Another thing that we all need to know is what is this mediator. So mediators, they are classified either as primary or secondary. These primary mediators are produced before degranulation and are stored in the granules. These are already present inside the mast cells, means they are stored in the granules. The secondary mediators, they are either synthesized after target cell activation or are released by the breakdown of membrane phospholipids during the degranulation process. The differing manifestation of type 1 hypersensitivity in different species or in different tissues partly reflects variation because of these primary and secondary mediators that are present. So some of the examples in detail about primary and secondary mediators. Primary mediators like histamine, heparin, they cause increased vascular permeability and smooth muscle contraction. Even serotonin acts in the same manner. We have got eosinophilic chemotactic factor, ECF, which causes eosinophil chemotaxis. Then we have neutrophil chemotactic factor, which causes neutrophil chemotaxis. We have proteases released, especially in case of asthma, where there is bronchial mucus secretion, degradation of blood vessel basement membrane and generation of complement split products. Some of the examples of secondary mediators and how they act. We have got PAF or platelet activating factor, which causes aggregation and degranulation of the platelets, and also it causes contraction of the smooth vessels. We have leukotrienes, prostaglandins, which cause increased vascular permeability and contraction of pulmonary smooth vessels. Bradykinin, it causes vasodilation and contraction of pulmonary smooth muscles. Cytokines, for example, interleukin 1, tumor necrosis factor alpha, interleukin 2, 3, 4, 5, 6, tumor growth factor beta, and granulocyte monocyte colony stimulating factor. All these, they contribute in systemic anaphylaxis, increased expression of on venular endothelial cells can be seen. So mechanism of type 1 after we have understood this concept, what exactly are allergens, what all matters in an allergen to cause any reaction, and what are the various mediators, let's try to understand in detail the mechanism of type 1 hypersensitivity. There is a sequence of reaction that's happening. So the typical sequence of event, it consists of exposure to an antigen. There should be an exposure to antigen, allergen for example, then which will lead to activation of type 2 helper cells that are specific for that antigen, production of IgE antibody, binding of the antibody to Fc receptors that are present on the mast cells. This triggers the mast cells by re-exposure to the antigen on consequent exposure, resulting in the release of mediators from the mast cells, and the subsequent pathologic reaction can be observed. So this a diagrammatic representation at the line of the cells. This is the lining of alveoli. These are the mucosal lining of respiratory tract in general. This is exposure to the allergen. Where allergen is pollen comes and binds to the mucosal lining cells. Then dendritic cells come into picture. There is activation of this naive T cells and ultimately type 2 helper cells activation takes place. This stimulates the B cells. There is class switching that's occurring here, which ultimately leads to production of IgE antibodies in a large amount. These IgE antibodies that are produced, they bind to these Fc receptors. They are present on the surface of the mast cells. So there is ultimately a complex formed because of this IgE antibody bound on the Fc receptors. What happens exactly after this? So what happens here? All this together, there is release of signals. These signals, they release the primary mediators that are already present in the granules. Okay, because of degranulation, the primary mediators are released, which are those the granular contents like histamine and proteases. So we have discussed there are primary and secondary mediators. So due to the consequent signals for cytokine gene activation and signals for activation of phospholipase A2 and membrane bound phospholipids, all these are stimulated simultaneously, and secondary mediators like leukotrienes and cytokines are released, prostaglandins D2, leukotrienes, platelet activating factors, all these are released. So when all this is happening, we see immediate reaction like vasodilatation, vascular leakage and smooth muscle spasm in case of acute reaction. As part of late phase reaction, we see leukocyte infiltration, epithelial damage and bronchospasm. This is over a period of time. So immediate is this wheel and flare reaction. So here we see it in a more clearer way where allergen is binding to IgE antibodies. This is the B cell class switching. Then this is the Fc receptor on the, this is the type 2 hyper Th2 cells that's activated. That was primary thing. Secondary, because of the retention of memory, consequently when there is re-exposure by the allergen here, the memory that is present here, the allergen has come here into picture. This is the Fc receptor for this IgE, and that because of the memory retention, there is release of this allergens. Allergen bind to IgE and Fc receptor. This causes release of this primary mediators and secondary mediators. So ultimately what's happening here, there is smooth muscle cell contraction, small blood vessel contraction, mucosal gland stimulation leads to large amount of mucus secretion here, blood platelets and sensory nerve endings, and there is large amount of eosinophil production. Type 1 reactions can be systemic or localized. So whatever this has happened, we have seen here. So the presentation, it can be just localized, limited to one organ, or a systemic manifestation as anaphylaxis can be seen. Localized or atopic reactions include allergic rhinitis, some of the examples here, asthma, atopic dermatitis, eczema and some food allergies. Systemic manifestations we can see as systemic anaphylaxis. So usually it runs in families, as I told you, we call it atopy. Anaphylaxis when we see a gross general reaction. So localized anaphylaxis or atopy, it is limited to an organ or tissue. So these are some of the examples. Then atopy, it always runs in families because of high levels of IgE and there is increase in eosinophils. Allergic rhinitis, few slides will have consequently about this localized presentation. First one, allergic rhinitis, what's happening here? Reaction of these airborne allergens with sensitized mast cells in the conjunctiva and nasal mucosa. It ultimately leads to release of this pharmacologically active mediators from the mast cells. This causes localized vasodilation and increased capillary permeability. So what's the presentation here? We see watering of the conjunctiva, exudation of the watering and exudation of the conjunctiva here, nasal mucosa and upper respiratory tract. We see there is gross congestion. That's the reason there is abundant sneezing and coughing. Asthma, common manifestation of localized anaphylaxis. This affects the lungs. The early response occurs within minutes of allergen exposure and primarily involves histamine, leukotrienes and prostaglandins. The effects of these mediators leads to bronchoconstriction, vasodilation and some buildup of mucus. This is the reason we hear wheeze in an asthmatic patient. As part of late response that occurs hours later, and it involves additional mediators including interleukin 4, 5, 16, tumor necrosis factor, eosinophil chemotactic factor. So this is just a pictorial representation of asthmatic patient. This is the early response what we are seeing, where there is release of histamine and prostaglandins here, and it causes small amount of vasodilatation and mucus secretion from this mucus glands. This is the early response where there is only a little bit of secretion. This is the late response where we see what was the exact definition of hypersensitivity. It is reaction is happening in an increased rate and there is damage. So here in late phase we see there is damage as epithelial injury and there is abundant deposition of these neutrophils, eosinophils, and there is this Cushman spirals that is seen here. There is also this thickened basement membrane because of the changes that are happening, and we saw the secondary mediators in abundance that are released here. They recruit these inflammatory cells, then inflammatory cells like eosinophils and neutrophils come into picture and abundant deposition of these cells takes place here. So we see in early response we have primary mediators that were present like histamine and prostaglandins that cause vasodilatation, bronchoconstriction and a small amount of mucus secretion. As part of late response we saw all these interleukins, interleukin 4, 5, tumor necrosis factor, eosinophil chemotactic factor, which cause this leukocyte migration activation and increased endothelial cell adhesion. So food allergies. Various foods also can induce localized anaphylaxis in allergic individuals. Allergen cross-linking of IgE on the mast cells along with the upper and lower GI tract can induce localized smooth muscle contraction and vasodilation. They cause symptoms of vomiting and diarrhea. Now a slide on atopic dermatitis. Atopic dermatitis or allergic eczema is an inflammatory disease of the skin that is frequently associated with family history of atopy. This disease is observed most frequently in young children, often developing during infancy. Serum IgE levels are often elevated in these individuals. The allergic individual develops skin eruptions that are edematous and filled with pus. So after taking any allergen food substance like fish or egg, whatever, depending on the allergic substance, you see the development. In case of Prosnitz-Kutnik's reaction, this is one Kushner reaction. This is original method of detecting atopic antibody, first reported by Prosnitz and Kushner. This test is performed on skin. Ig antibodies on skin cells from the basis of this reaction, not done nowadays due to risk of transmission of serum hepatitis. Then we have systemic anaphylaxis. It's a shock-like and often fatal state. It occurs within minutes of type 1 hypersensitivity reaction. Allergens included here are venom from bee. The examples are insect bite, snake bite, drugs such as penicillin, antitoxins and ingestion of seafoods can cause this systemic anaphylactic reaction. The case scenario, the first slide which I had put was an example of this. Cytotrophic IgE antibodies are responsible for this reaction. It is not hereditary. The difference here between atopy and anaphylaxis is this is not hereditary. It can be induced artificially by using serum. If not treated quickly, this reaction can be fatal. So this is a video demo where you see an insect bite, the bee venom ingestion, and how the allergen goes and is taken up by this dendritic cell. This is the naive CD4 T cell. There is activation of this type 2 helper cell, which stimulates this B cell. There is class switching in B cell and there is abundant amount of production of IgE antibodies. These IgE antibodies go and bind to mast cells on the Fc receptors present on the surface of the mast cells and ultimate release of large amount of cytokine release can be seen, which causes various presentations. We can see vasodilatation, and release of exudates. That's the reason for this wheel and flare reaction. These are the urticarial rashes that are seen in this individual because of this anaphylactic reaction that's happening. The types of anaphylaxis. Anaphylaxis in vitro, an example of a gain-epic experiment. Then cutaneous anaphylaxis, where we see local wheel and flare response. Passive cutaneous anaphylaxis, in vivo method of detection of antibodies done in animals. Regulation of type 1 hypersensitivity. It totally depends on the genetic makeup of the individual, nature and dose of the allergen that was induced, presentation of the allergen, whether there was any adjuvant present or it was just the allergen, and the type of immune response. Detection of type 1 hypersensitivity can be done by using skin test. Small amount is injected intradermally. In sensitized person, response is seen as local wheel and flare in 30 minutes. Detection of total serum IgE antibodies by radioimmunosorbent test. Then detection of this allergen specific IgE antibody by fluoroenzyme immunoassays. Then radioallergosorbent test. So atopic allergies and their treatment, a better concept in pharma can be understood, but in short, best treatment would be avoidance of the allergen. When a person knows that he is allergic to dust, better to avoid that. Like if he is allergic to any seafood, better to avoid that. And we can act at the level of IgE synthesis, hyposensitization, or we can use trigger cell stabilization. Then we can use mediator antagonists like histamine antagonists. Then recruitment of eosinophils. In later stages, late phase inhibitors can be used. So this is an example. Again, better concept in pharma can be understood. These are some of the drugs: antihistamines, epinephrine, cortisone, theophylline, cromolyn, sodium, and the level where it's acting. Antihistamines, they block the histamine receptors. Then epinephrine stimulates cyclic AMP production in mast cells. Cortisone blocks conversion of histidine to histamine. Theophylline prolongs high cyclic AMP levels in the mast cells. Cromolyn sodium blocks calcium influx into the mast cells. So type 2 hypersensitivity, this cytotoxic reaction is mediated by IgG directed against the antigens, and the surface of cells, it results in cell damage. So what we have to remember here, in type 1 it was IgE antibody, in type 2 basically it is IgG antibody. And antibodies bind to antigens on the surface of the cells here. Phagocytosis of the cells through immune adherence, cytotoxicity by natural killer cells, lysis through activation of the complement system. So this is antibody dependent cell damage, antibody dependent cytotoxic hypersensitivity. This type of cytotoxicity is due to natural killer cells here. IgG antibodies coat on the target cells by combining with the surface antigen through the FAB region. It is involved in destruction of target cells which are too large to be phagocytosed. Examples: tumors and grafts. So these are some of the clinical conditions where we observe this type 2 hypersensitivity reaction, like Graves, myasthenia gravis, Goodpasture syndrome, autoimmune hemolytic anemia, Rh incompatibility, ABO incompatibility, where it is because of mechanism here, long acting thyroid stimulating antibody to the thyroid membrane. It's all acting on the cell surface. Antigen, anti-acetylcholine receptor antibodies to acetylcholine receptors. Here it's antibody against the basement membrane of the glomerulus Bowman's capsule. Autoimmune hemolytic anemia, it is anti-erythrocytic antibodies to RBCs. Rh incompatibility, it is anti-Rh antibodies to Rh positive fetus. ABO incompatibility, recipient antibodies are formed against RBCs of incompatible donor. This is just a picture of Rh incompatibility where we see the damage that's happening. First pregnancy is safe. In the second pregnancy, because of retention of memory by this IgM memory cells, we see in consequent pregnancy, these memory cells come into picture, they recognize it as foreign, and there is this erythroblastosis fetalis. So concluding with our first slide, so we had a scenario where an 8-year-old presented with cellulitis. She has never taken penicillin injection in the past. Now after she is given a second dose, she collapses. So first there was sensitization dose. First time when she had taken, that time there was no reaction. Second time when on exposure to the same drug, penicillin, there is this shocking dose and where she has experienced anaphylaxis. So we conclude this hypersensitivity, we understood that it's an exaggerated immune response. It's not just exaggerated, we should observe that there is some damage. So which are the various types of hypersensitivity? Type 1, type 2, type 3, type 4. There are two classifications, Coombs and Gell classification and the traditional classification, immediate and delayed type, where in traditional classification, immediate we have 3 and delayed we have type 4. Immediate one is because of B cell stimulation and delayed type is because of cell mediated ones. So here we had a short discussion about type 1 and type 2. In type 1 hypersensitivity, we discussed the definition where there is hyper exaggerated immune response and local damage, and the main antibody that was involved here was IgE antibody. Before we discussed few slides on allergen, what exactly it is, and what all depends on initiating this reaction, the nature, the dose, any adjunct present and all that. Then we discussed what are mediators. We discussed that there are two types of mediators, primary mediators and secondary mediators. Primary mediators, they are already present inside the granules. Secondary mediators, they are released on after this binding of this IGFC receptor complex and there is signal release. So we saw that initially with the help of pictorial representation how an allergen comes and bite on the surface and how the T helper type 2 cells are activated. They go and communicate to these B cells and there is class switching and large amount of release of this IgE antibodies. This will ultimately go and bind to the mast cells, FC receptors present on the mast cells, and they primarily release the primary mediators that were already present like histamine and serotonin. Then because of this signal transduction, membrane phospholipids and secondary cytokines, leukotrienes were also released like eosinophilic chemotactic factors and interleukins 2, 4, 6 and all. Ultimately what we saw was the effect it caused, like there was local virulent flare reaction because of this vasodilatation and large amount of these secretions, and there was damage also. We saw it with the help of few case scenarios and few slides like for example atopy, the atopic dermatitis where the reaction was occurring at the skin level local, and then food allergies where it was involving the GI tract, and we saw allergic rhinitis where the local allergy was at eyes and conjunctiva and the nasal mucosa, and then we saw discussed about systemic anaphylaxis where we see this reaction in case of any drug induced or any insect bite venom. I think the pictorial representation and a video demo was clear for understanding. So I would like to conclude, and a few discussions on type 2 hypersensitivity slides were there where we saw it was because of IgG antibodies, and the reaction was occurring on the level of the cell surface. We saw there were examples, Graves disease, myasthenia gravis, and there is RH incompatibility seen in newborn. This was just a short discussion about type 1 and type 2 hypersensitivity. I hope I could give a crisp idea about this concept. Thank you one and all for your patience hearing.